For centuries in many societies, infertility was assumed to be the woman's fault. Women were shamed, replaced, pressured to fix themselves, and in some cases even punished or harmed. Meanwhile, male fertility was rarely questioned. That was not because men were always fertile. It was because admitting male infertility challenged a powerful social belief that fertility equals masculinity. That legacy still shows up today. In many fertility journeys, women are tested first, monitored more closely, and expected to do the tracking, the lifestyle changes, and the emotional labor. Men are often treated as supporters, not equal patients, even though fertility involves two people. And when the burden is uneven, time gets lost. In fertility, time matters. Male factors are involved in a significant share of fertility problems, and many couples have more than one contributing factor at the same time. So if you have been quietly asking yourself, is it me? The honest answer is often this: it may be shared, or it may not be what anyone assumed. This is why fairness in fertility care matters. When the default is to investigate and treat the woman first, couples can spend months or even years chasing the wrong explanation, and women often carry the physical and emotional cost of that delay. Today, as we pretend to be in a civilized, more empathetic world, women are being fairly given some support when it comes to fertility. However, many women will still recognize this pressure pattern immediately when fertility appointments are built around her body. The conversation focuses on her cycle, her weight, her hormones, and her uterus. The language can be subtle, but it lands hard. We'll just start with you. Let's make sure everything is fine on your side. He's probably okay. You've already had one child, so it must be you. This is not about blaming individual clinicians. It is about naming how social assumptions can shape medical pathways and household dynamics. If semen analysis is treated as optional, delayed, or too sensitive to discuss, women often end up doing more tests, accepting more procedures, and carrying more uncertainty, even when the missing piece may be on the male side. I want to share a true story approved by the woman herself. For privacy, I will call her EA. EA and her husband had their first child, a baby boy. After that, they tried for another baby, and nothing happened. 1 year passed, then 2, then 5. EA sought medical help and attended appointments. Doctors told her that her tests suggested she was capable of conceiving, but her husband refused to attend any appointments because they already had a child, and he assumed that meant he must be fertile. Eventually, they agreed to see a fertility doctor, but the framing was familiar. They went to learn how they could support the woman. That was the only way EA could get him into a fertility discussion through the GP pathway. When semen analysis was suggested, he refused. He said he would go to a private fertility clinic instead. He did go privately, and the test showed low sperm motility. But he did not share the results with his wife. EA found the results by chance while doing laundry. They were in his pocket. When she confronted him, he said, "Low motility doesn't mean I don't make viable sperm." He had been advised to reduce alcohol. EA had raised the alcohol issue many times. She asked him to stop drinking for a defined period to support their chances, based on guidance from fertility experts. But he continued drinking in secret most nights, even after work. All of this happened while EA remained the one going through repeated fertility investigations. Years passed. By the time their first child was 12, EA had spent 7 years trying to get her husband to cooperate in a meaningful way. During her testing, doctors found uterine fibroids. She was told she could still conceive and that the fibroids were not actively blocking fertilization pathways. But her husband blamed the infertility on her fibroids and pressured her into surgery, just in case. EA went through the surgery, but after 3 more years, her husband still showed no consistent effort to improve sperm health, no transparent engagement with the fertility plan, and no steady commitment to timing intimacy to improve their chances. When the fertility topic was raised, the situation escalated into domestic abuse. EA requested a divorce through her lawyers. She was 40 at that point and constantly worried about having only one child as she approached perimenopause. Later, she met another man and became pregnant within 6 months. She gave birth to a healthy baby girl. Her ex-husband reacted with rage and accused her of infidelity, even as the divorce papers were being signed. EA said she could not wait any longer. She was getting closer to menopause, and she asked a question many women feel but rarely say out loud. Who carries the babies after menopause? While a man may still have time to improve fertility and have children even decades later. Yes, there are modern options that can help some people later in life, such as IVF with frozen embryos or donor eggs. But the next question is important. Why turn a manageable issue into a mountain and then spend heavily on in vitro fertilization, when basic steps could have been taken seriously from the start? Some people raised eyebrows at how quickly she conceived with a new partner. There is no judgment here. We are only focusing on the facts. This story is not shared to shame anyone. It is shared because it shows how denial, secrecy, and unequal responsibility can steal years from a couple. And it shows how women often pay the highest price in time, health, and safety. I have left links in the description to similar public fertility stories if you want to read more. And if you have any similar stories to share to inspire our audience, send it to our contact email in the description. We will discreetly share. There is a particular kind of grief that comes from being told again and again that your body is the obstacle, even when the evidence is uncertain. Do this scan, take this medication, have this procedure, just in case. It can feel like you are constantly proving your innocence in a case you never asked to be judged for, and this is not rare. In NHS fertility patient stories, women describe months and years of tracking, investigations, injections, procedures, and emotional strain. Because when fertility becomes difficult, the medical journey often happens through the woman's body first. Even in supportive stories, you can hear how heavy the physical burden becomes, and how easily the woman's body becomes the main site of intervention. Male fertility issues can come with intense shame, and shame can push couples into silence or delay. In one NHS hospital story shared publicly, a man described being told he had a low sperm count. He felt inadequate, questioned himself, and found it difficult to talk about. He also described something important. Once he opened up, he realized how common it was. Talking to friends helped break the taboo. This matters on a women's health channel because when male factor becomes unspeakable, women often carry more of the visible work, while men carry the invisible fear. The only way through is shared truth, shared testing, and shared support. Male infertility is not a character flaw, and it is not a measure of worth. It does not cancel masculinity. Clinically, male factor fertility problems often come down to sperm count, motility, and morphology. Sometimes it also involves how sperm is delivered, sometimes results fluctuate, and sometimes fertility struggles involve more than one factor across both partners. This also needs to be said clearly. Having conceived in the past does not guarantee fertility forever. A key principle in fertility care is that initial investigations should involve both partners. That matters because it reduces delays and prevents a situation where one person undergoes repeated testing while the other remains unassessed. If you are already doing blood tests, scans, and tracking, it is reasonable to ask whether semen analysis and relevant screening are being done alongside, not months or years later. Testing is not an accusation, it is information. And information is what turns fear and blame into a plan. Semen analysis is the main test used to assess male fertility. It looks at how many sperm are present, how well they move, and features of their shape. If the first test is abnormal, another sample may be requested to confirm the pattern. When semen analysis is delayed or avoided, women can end up carrying the entire medical journey, even though the missing information could have changed the plan much earlier. It can also distort the emotional story inside a relationship. One person becomes the problem and the other becomes the judge, instead of both partners facing a shared challenge. If you want to go deeper into modern fertility tests and diagnosis, a video has already been published on this channel. I will leave a link in the comments and in the description so you can watch later. Lifestyle advice is often presented as simple, but living it is not simple when the sacrifice is uneven. If one partner is cutting alcohol, improving sleep, timing intimacy, and carrying the emotional strain, while the other continues habits that may reduce fertility, the result is not only a lower chance of conception. The result can be resentment, loneliness, and the feeling of being unsupported in your own life. If you are on a fertility journey, it is reasonable to ask for a defined period of shared effort. Not forever, not perfection, but a real time-limited commitment where both partners align their choices with the goal they say they want. Some situations justify earlier fertility assessment. These include known testicular problems such as epididymitis, torsion, lumps, swelling, or persistent pain. They also include previous cancer treatment, ejaculation problems, or a significant infection history. It is also important to name a different kind of red flag. If fertility conversations trigger coercion, intimidation, control, or abuse that is not normal, you deserve support and safety, and you are not too sensitive for wanting your health and future to be handled with care. If you want to shift the conversation from my fertility to our fertility, language matters. Try words that protect connection while still demanding fairness. You can say, "I want us to get clarity together." "I'm happy to do tests, but I need this to be equal and shared." "Time matters for my body, and we can't afford delays." "I'm not looking for someone to blame, I'm looking for a plan." You can also ask directly at a GP appointment, "Can we arrange initial fertility tests for both of us at the same time? Can semen analysis be included early? If anything is abnormal, what is the next step and what is the timeline?" The goal is not to shame. The goal is to stop the quiet shaming of women that happens when male factors are ignored. The burden was never meant to be yours alone. Watch this video next to refresh your understanding of how fertility works and when to seek support for both partners.